Hello, I'm Heloasa Pereira Galvão de Carvalho, Brazilian Medical School student from Escola Baiana de Medicina e Saúde Pública in Salvador, Brazil. And my second author is my professor, Neide Aparecida Micapoulos. She's a pediatric cardiologist, and she currently is the director of the Department of Pediatric Cardiology in Jorge Valentes Hospital, also in Salvador, Brazil. And today I'm gonna present my presentation about early intrauterine diagnosis of Scimitar Syndrome and postnatal diagnosis of pulmonary sequestration in a private maternity in Salvador, Bahia, Brazil, a case report. Giving you guys a little bit of a background about our article. Scimitar syndrome is a rare congenital anomaly associated with partial anomalous pulmonary venous return or total anomalous pulmonary venous return, hypoplasia of the right lung and artery, systemic arterial supply to right lung, and often is associated with pulmonary sequestration. And prenatal diagnosis of Scimitar syndrome still remains challenging, especially in developmental countries such as mine. The objective of our article and this presentation is to report a rare intrauterine diagnosis of Scimitar syndrome, also to describe postnatal identification and management of pulmonary sequestration, and to highlight the diagnostic role of fetal echocardiography and postnatal computerized tomography, or CT, in angiography. Talking about the case summary. During the prenatal phase, we received a 34-year-old primigravida in our hospital. She had at first normal prenatal screenings, but at 25 weeks, the fetal echocardiography showed partial anomalous drainage of right pulmonary veins to the inferior vena cava, mesocardia with no dextroposition. And at 32 weeks, the diagnosis of Scimitar syndrome was confirmed with right pulmonary artery hypoplasia and right heart chamber dilation. If you look at the right, we have two pictures from the echocardiograph at 31 weeks, and in this one you can see the partial anomalous drainage of the right pulmonary veins to the inferior vena cava. And at the bottom, you can see the right heart chamber dilation. Postnatal imaging and diagnosis. The male newborn was delivered at 36 plus 5 days. He had an Epigar score of 8 in the first minute and 9 in the fifth minute, and he was initially stable. He was admitted to the NICU, or the neonatal intensive care unit, due to Scimitar syndrome's diagnosis, and we assessed an early postnatal echocardiogram, which revealed to us a partial anomalous pulmonary venous return to the inferior vena cava, which is known as the Scimitar vein. Also, a mild pulmonary hypertension. The partial pressure of these particular arteries was 50 milligrams of mercury, and no obstruction of pulmonary venous return was assessed. On the fifth day of his life, a computerized tomography angiography was conducted, and the Scimitar syndrome was confirmed with hypoplastic right lung. And also, we identified intralobar pulmonary sequestration, and we also found he had an arterial supply from celiac trunk and thoracic aorta. At 16 days of life, he was admitted to endure successful transcatheter embolization of systemic collaterals. The procedure was used to improve his breathing and to treat his lung condition. And the procedure was assessed by using ENBO spheres and microcoils. And it was a successful procedure that reduced pulmonary arterial pressure. And the patient was later referred for surgical correction of partial arterial pulmonary vein return due to the Scimitar Syndrome. About his outcome and follow-up, post-embolization, the infant remained hemodynamically stable following catheter-based embolization of anomalous systemic arteries, and no signs of heart failure, cyanosis, or respiratory distress were noted post-procedure. He was able to endure oral feeding. He tolerated oral feeding, and weight gain was within normal limits of his age, comparing him to a healthy child. The long-term follow-up, at 8 months of age, the child remains asymptomatic with normal growth and neurodevelopment. He also exhibits stable cardiopulmonary parameters. He is under outpatient follow-up by our Pediatric Cardiology department, and surgical correction of the infracardiac partial abnormal pulmonary venous return is planned electively, given the absence of urgent clinical indications. So in our discussion, we discussed that fetal echocardiography demonstrated that isolated partial anomalous pulmonary venous return may serve as an early and sufficient marker of Scimitar syndrome, even in the absence of cardiac dextroposition, echogenic lung alterations, or obstructive venous flow, which in the current literature is these are the parameters for assessing an early intrauterine diagnosis. We also discussed about the importance of imaging modalities, so the computer tomographic angiography, in this case in particular, was crucial for confirming the presence of pulmonary sequestration and also allowed in the identification of systemic to pulmonary arterial collaterals and guided target embolization strategy. The therapeutic strategy for this patient was the earlier catheter embolization, which effectively reduced left to right shunting and pulmonary artery pressures. And the deferral for surgical correction of the partial arterial pulmonary venous return was safely possible due to the child's stable clinical. And we conclude emphasizing that the diagnostic value of fetal echocardiographic in detecting Scimitar syndrome as early as the third semester, even with minimal features such as we saw in this case, is possible and is actually valuable for assessing early management and for planning for a surgical correction. The combination of prenatal echocardiography and postnatal computerized tomography angiography facilitated comprehensive assessment and timely intervention. The early identification and management of associated pulmonary sequestration can significantly improve neonatal outcomes and also reduce complications related to pulmonary hypertension. And this approach underlines the importance of multinatal imaging and interdisciplinary coordination in the care of congenital pulmonary anomalies. Thank you.